Hello, good afternoon, everyone. Thank you for your coming to this symposium. My name is Masafumi Mizuno from Tokyo. This symposium titles New Models of Psychosocial Rehabilitation in Early Phases of Psychosis, and proposed with Dr. Vinci, Giancarlo Vinci from Rome, and we have proposed this symposium. That is why we both of us are working in the very, very clinical settings, and sometimes we see very young people with the first episode or at-risk mental state. And usually, pharmacotherapy or psychopharmacological study is sometimes stressed in this type of conferences, but to discuss about psychosocial approaches is very difficult, and getting the data through this type of study is more difficult. But we really believe that to increase, to stimulate this type of approach, I mean integrated approach, both psychosocial and pharmacological approach should be done, prepared at the same time from the very, very beginning of the first episode of psychosis. So this time we have proposed this symposium with the name of New Models, but it depends on the region or places. It is difficult to get the same medicine in different parts of the world. It's easier. But to get the same approaches to the patients from psychosocial view is a little bit difficult. So this time we have 4 speakers from different regions, one from Tokyo and one from South Korea, and one from 2 from Italy, but one from Rome and one from Naples. So let's start the symposium from the first speaker, Professor Nemoto Takahiro from Toho University, Tokyo. Please have a talk. Thank you very much.
Thank you for the introduction, President Mizuno. And thank you for the opportunity to present our recent work. Today, I'd like to talk about the feasibility of cognitive rehabilitation during the acute phase of schizophrenia. There are no conflicts of interest. First of all, deficits in cognitive function, including attention, memory, and executive function, are core features in schizophrenia. Cognitive deficits are key determinants of impairments in social functioning and are associated with long-term outcomes. The development of cognitive rehabilitation and an examination of its effectiveness have been undertaken with the aim of improving cognitive and social functioning in patients with schizophrenia. Not only can cognitive rehabilitation improve cognitive function, but it can also improve social functioning to some extent. Rehabilitation is generally divided into 3 types according to the stage of disease. Acute rehabilitation is implemented for 2 to 4 weeks after the onset or relapse of disease. Convalescent rehabilitation is implemented for about 6 months during the subacute phase, and maintenance rehabilitation is continued during the chronic phase. In psychiatry, rehabilitation is mainly implemented during the chronic phase, and rehabilitation during the acute phase is unusual. In the field of physical medicine, on the other hand, An early start to rehabilitation has been reportedly correlated with a better outcome. For patients with cerebral vascular diseases and traumatic head injury, in particular, the importance of acute rehabilitation for physical and cognitive function has been emphasized. As part of treatment during the acute phase of schizophrenia, adequate rest is certainly necessary. However, the findings for the other neural diseases, such as cerebral vascular disease and traumatic brain injury, suggest that the early start of cognitive rehabilitation might also be beneficial to patients with schizophrenia. Nevertheless, psychiatric rehabilitation during an acute disease phase includes a number of problems that must be overcome, such as psychiatric symptoms and a lack of volition. Only a few reports have discussed cognitive rehabilitation during the acute phase of schizophrenia. Beckdorf reported a study in which inpatients with schizophrenia who were within 14 days of hospital admission were randomly placed in an 8-week treatment program consisting of either group cognitive behavioral therapy or group psychoeducation treatment. Although the patient's quality of life improved significantly after both treatments, a direct approach to cognitive function rehabilitation was not used. Medallia reported a study examining short-term problem-solving remediation in acutely ill psychiatric inpatients. However, detailed information regarding the acute phase was not described. By the way, in psychiatric treatment in Japan, hospital-based psychiatry and long-term hospital stays were common for many years. However, a transition from hospital-based treatment to community-based treatment has recently been promoted. Actually, the number of inpatients with schizophrenia is decreasing, and the length of the hospital stay has also gradually decreased, as shown by the line graph. These show the importance of developing a strategy for acute phase treatment given the present situation of psychiatry in Japan. Now I'd like to introduce our hospital, the Toho University Omori Medical Center, located in the southern area of the Tokyo metropolitan region. The population of the catchment area is about 1 million. We established a multi-dimensional treatment center for early intervention in 2007 that consists of the acute psychiatric ward, youth clinic, and the special youth daycare service Il Bosco. Our center is well known as a proactive institute for early intervention in Japan. We hope to develop acute phase treatment strategies to improve patients' prognosis. Cognitive deficits are commonly found in patients with schizophrenia. However, in an acute care setting, treatment efforts do not typically target cognitive deficits, even though they can impede a patient's recovery. Therefore, the aim of the present study was to examine the feasibility of cognitive rehabilitation during the acute phase of schizophrenia. During a 15-month period, in patients with schizophrenia between the ages of 15 and 50 years were recruited for this study at the Toho University Omori Medical Center. Among them, patients who agreed to participate in this study and were able to start the acute cognitive rehabilitation program within 2 weeks of their hospital admission were considered as subjects for this study. An 8-week cognitive rehabilitation program that used a workbook style was developed, taking the patient's conditions and burdens during the acute phase of schizophrenia into consideration. Each participant received a new workbook weekly and was instructed to do exercises for 20 minutes every day. Clinical psychologists visited and supported the subjects several times per week. Clinical and cognitive assessments were administered at baseline and after the rehabilitation program. The workbooks contained various exercises to improve basic neurocognition and divergent and convergent thinking. Furthermore, materials about interpersonal relationships and social context were also included in the workbooks. "83 patients with schizophrenia were newly admitted to the hospital during the 15-month study period. 43 were men and 40 were women. The mean age was 31.9 years old. After screening according to the exclusion criteria, such as admission to initiate clozapine treatment, a planned early discharge, a planned change to another doctor that had already been decided, or intellectual or physical problems. 49 patients were considered to be eligible for inclusion in this study. Of them, 22 patients, or 45% of the eligible patients, agreed to participate and started the cognitive rehabilitation program. The reasons why the remaining 27 patients were not included in the study included of poor clinical condition, refusal to participate, doctor's decision, and so on. Results. The demographic and clinical backgrounds of the 22 patients who were enrolled in the study and began cognitive rehabilitation during the acute phase of schizophrenia are shown in the table. The patients consisted of 10 men and 12 women. Their mean education level was senior high school graduation, and their mean estimated IQ was about 100. The interval from admission until the start of the program was 9 days. The mean GAF score was 32.3, indicating relatively severe psychopathology and functioning. The GCOS is a scale for evaluating motivational personality. A high intrinsic motivation, as indicated by the GCOS-A subscale, was characteristic of the patients who underwent cognitive rehabilitation. Sixteen patients completed the 8-week cognitive rehabilitation program and underwent a second assessment. Thus, 73% of the participants who began the program actually completed the study, representing 33% of all the eligible patients. Regarding the demographic and clinical backgrounds of the participants at baseline, no significant differences were seen between the patients who completed the program and those who dropped out. The GAF scores of the patients who completed the program improved significantly from a mean of 31.9 to 51.3. Among the patients who completed the program, their satisfaction with the program, as indicated using a 10-point Likert scale, was as follows. The mean score for enjoyment was 6.8. That for usefulness was 6.7. And that for difficulty was 5.6. The participants seemed to be quite satisfied with the program, and the difficulty of the exercises seems to be appropriate. The completion rate for the exercises in the workbooks was 73%. Further detailed analysis are planned. Early intervention for the treatment of schizophrenia can be considered as an intervention performed during the early stage of the disease course, or as an intervention beginning soon after the start of the disease episode, that is, during the acute phase. The provision of cognitive rehabilitation during the acute phase of the first episode can reasonably be expected to lead to better functional outcomes. Furthermore, rehabilitation using a workbook format is thought to be appropriate for the acute phase, since rehabilitation can be performed at the patient's bedside according to a safe and individual approach. Conclusion. About half of the eligible patients participated in the cognitive rehabilitation program. The mean interval from admission until the initiation of the program was 9 days. After enrollment in the program, 72.7% of the subjects completed the 8-week program. The mean completion rate of the exercises in the rehabilitation workbooks was 73.2%. The safety and usefulness of a workbook and paper and pencil style format was demonstrated. We concluded that even during the acute phase of schizophrenia, during which patients exhibit significant psychiatric symptoms and functional impairment, as shown by a GAF score of around 30. The introduction and continuation of cognitive rehabilitation is possible in many cases. Thank you for your kind attention.
So, we have time for a question. Okay, I have a question for you. Which kind of patients can be introduced in your program?
Thank you. Thank you, question. As I told in the result section, patients who could be introduced into this program had a tendency and characteristics of they have a kind of personality that could be motivated easily. The GCOS score indicated that tendency. The GCOS is motivational, the scale for motivational personality. Therefore, I think patients who are really easily motivated, good subject for this program.
Thank you. Thank you.
Thank you very much.
Okay, so move to the second speaker, Professor Soon-Won Kim from Cheonnam National University Hospital. His title is Group Cognitive Behavioral Therapy and Smartphone Application for Young Individuals with Early Psychosis. Professor Kim, please.
Thank you. Good afternoon. Today's my topic is on group cognitive behavioral therapy and smartphone application for young individuals with early psychosis. Patients with a psychiatric disorder have high levels of self-perceived stigma, which frequently prevents successful treatment. This negative stigmatizing effect of mental health has been observed in the early stage of illness. The DUP is related to a poor prognosis for patients with schizophrenia. It is comparatively long in Korea relative to that of Western countries. The high stigmatizing social environment and poorly developed mental health system may contribute to such long DUP in Korea. Since mid-1990s, early intervention service have been provided in specific early intervention centers worldwide. However, most centers are in Western countries. In Asian countries, Singapore and Hong Kong have special early intervention centers. In Korea, 10 years ago, a few early intervention centers and research started. And I started early intervention center and research from my hometown, Gwangju. And the name of my early intervention service is GET-IT, Gwangju Early Treatment and Intervention Team. And this year, we opened new special community mental center for young people with early psychosis or at ultra high risk population, MindLink. I'd like to introduce a new early intervention center, MindLink. MindLink is the first special mental health service center based in community. This is youth-friendly and stigma-free mental health service center. MindLink aims to link clients to health service, treatment resource, education, employment, and recovery. And MindLink aims to link between community mental health service and hospital treatment, to link between mental health and physical health, to link between client and family members. Our early intervention service, the key component of our early intervention service is intensive case management, family intervention, physical health promotion, and group CBT program. I'd like to introduce my first studies background. The efficacy of cognitive behavioral therapy for schizophrenia has been well established. However, there is less evidence regarding group CBT for people in the early stage of psychosis, particularly in Asian countries. This study aimed to develop a model of group CBT for Korean patients with early psychosis. Group CBT program of Mindlink consists of 3 parts: metacognitive training, cognitive restructuring, and lifestyle management. The first part of Group CBT of Mindlink is metacognitive training, developed from Hamburg University, German. MCT is a manualized group training program that targets dysfunctional coping styles and cognitive bias involved in the formation and maintenance of psychotic symptoms such as attributional distortions, jumping to conclusions, and impaired social cognition. After 5 sessions of the MCT, 3 sessions of cognitive restructuring using Beck's cognitive therapy model were conducted. And we provide 5 sessions of lifestyle management, including stress management, self-esteem enhancement, and the process of setting goals. This sequential combination of techniques may have synergistic effects. Method. Various scales, including SWN and ambiguous intentions, hostility questionnaire, were administered prior to and after CBT sessions. And the participants were categorized into 2 groups according to the median DUP, 4 months. Result. This study initially included 58 patients who participated in the group CBT program between September 2012 and December 2015. After excluding patients who did not meet inclusion criteria, a total of 34 patients were included in this analysis. The mean age of the participant was early 20s, and the median DUP was 4 months. There were significant increases in the SWNK and DAI scores, and significant decreases in the hostility subscale of the AIHQ, perceived stress scale, and CGI scores. And significant time by DUP interactions were observed in scores on SWN, DAI, and BDI. As you can see, scores on DAI are significantly increased in short DUP group, but not in long DUP group. Same pattern in subjective well-being and the neuroleptics. Scores of SWN were significantly increased in short DUP group, but not in long DUP group. BDI scores were significantly decreased in short DUP group, but not in long DUP group. The present findings demonstrated that the group CBT program for patients with early psychosis effectively increased subjective well-being and attitude toward treatment, and decreased suspiciousness and perceived stress. The improvements in well-being and attitude toward treatment were particularly significant in patients with a DUP that was shorter than 4 months, and the effect size were moderate to large, while suspiciousness and global severity improved regardless of the DUP. As I mentioned, the group CBT program in this study had 3 parts. The first part, MCT, aims to enhance patient awareness regarding cognitive biases and cognitive flexibility. Metacognition refers to the general ability to think about thinking. The programs that improve metacognition may help motivate patients to restructure their cognitive distortions, which are targets of the second part of my group CBT programs. Previous studies demonstrated that cognitive flexibility and the ability to consider alternative beliefs are predictors of better cognitive therapy outcomes. These previous studies have supported the potential effectiveness of the combination of MCT and formal cognitive therapy. The study findings showing significant improvements in the subjective responses in patients with a short DUP but not a long DUP support the need for early intervention in psychosis service in right time. Thus, delays in treatment may reduce the therapeutic potential of psychosocial interventions provided during the course of the illness. In the short DUP group, functional and developmental reserves against the toxic effects of long DUP may contribute to a favorable response following group CBT. A race study revealed that DUP influences the treatment response following comprehensive psychosocial services in patients with first episode psychosis. The authors of the race study proposed that reducing the DUP from its current level of about 1 year to a recommended standard of 3 months should be a major focus of applied research efforts. Our findings indicated that DUP shorter than 4 months may be critical to achieve good response to psychosocial interventions in Korean patients with early psychosis. Let's move to my second study, development and feasibility of smartphone application for cognitive behavioral case management of individuals with early psychosis. Approximately 4/5 of Koreans use smartphones, which is the highest rate in the world, and the Korean wireless internet is the fastest in the world. Moreover, most of the young patients who used community mental health service in Korea also reported having a smartphone. Thus, it is time to change the paradigm that structures the case management service provided to members of this digital generation who suffer from psychiatric illness. In 2013, we developed a smartphone application designed to deliver real-time case management and self-directed CBT services to young patients with early psychosis. This mobile application, named Heal Your Mind, HIM in Korean means power, has been updated to a second version with the same content in last November. The HIM application for clients includes 6 main modules, including thought record, symptom record, daily life record, official notices, communication, and scales. This is a screenshot of thought record diary. Actually, this is written in Korean. The key module of our smartphone application is the thought record for self-directed CBT, which helps clients change their dysfunctional beliefs to rational ones. When the client writes and sends the self-CBT sheet to the case manager, the case manager receives a notification and can provide feedback in real time. This can facilitate the self-CBT process and provide positive reinforcement. So after participating in the group CBT, they can use this smartphone application for self-CBT with case managers. Symptom record module allows clients to rate their psychiatric symptoms in terms of thought, voices, anxiety, depression, and perceived stress using an 11-point Likert scale and to provide a description of each symptom. Ratings by clients are stored in graphic form representing changes in symptom severity. These data are shared with case managers to help monitor clients' symptoms and signs of relapse. Daily life record module allows clients to record their daily life patterns with regard to social activity, exercise, and medication regimen. These data are also stored in table form and shared with the case manager to help with the management of daily lives. Communication module allows for personal conversation between clients and case managers. Client can send messages and case manager can respond in real time. We surveyed 24 subjects with a psychiatric disorder. The mean age was 25 years. The most frequent diagnosis was schizophrenia. The median duration of illness was about 2 years. More than 80% participants reported that it was easy to learn to use this app, and no one reported that this app to be very complicated. And about 70 to 80% participants reported that they can interact with case manager, and they are generally satisfied with the use of this app, and they received help as a result of using this app. A quarter of participants reported that they used the app at least once every 2 days, and 2/3 used it at least once per week. The module that allowed clients and case managers to communicate was used the most frequently, was the most likely to be used, and was the most helpful. The thought record module was the next most likely to be used modules. It is important to develop a special tool that meets the needs and fit with the lifestyle of young clients to engage this population in an intensive case management process at an early stage and critical period of their psychiatric disorder. Most clients who used a community mental health service for early psychosis reported that they were generally satisfied with this app and that it was helpful to them. In particular, most were able to interact with their case manager through this app, and no one reported any critical problems or difficulties using this app. The interactive function of this application is among the key characteristics that distinguishes it from other mobile self-treatment tools. Real-time feedback during self-CBT may increase clients' motivation to engage in treatment and help them to guide their efforts appropriately. This is particularly important for clients who experience difficulties adapting their dysfunctional beliefs to the lessons of CBT. In conclusion, this application is a useful and feasible tool for communicating with and providing real-time psychological support to clients with early psychosis. This is particularly meaningful given the young clients require intense case management at this critical period of their disorder. This study may contribute to the development of novel early intervention service for clients with early psychosis who reside in community settings. This will be published in international journal soon. Thank you for your attention.
Some questions? One.
Thank you. Very interesting presentation. I have a question regarding the personal communication and the chatting functions. How did you organize the availability of the case manager? Because I guess it couldn't be on a 24/7 basis.
Yeah. Thank you for nice question. Initially, clients announced that the chatting function are available only in working time, and we provide emergency phone call number after working hours.
Thank you. A comment from our president.
Thank you for your excellent presentation, and I'm very much interested in the APP. It's very, I think it's very useful for maintaining or keeping their adherence to the therapy for young people. But people who have participated in this study was 24, 25 years old, young but enough adult, already adult. How about when you use these materials for teenagers, like high school students or junior high school students? I worry a little bit because in your country and also Japan, we have a lot of internet dependency patients. And the problem, we have a special clinic for net-dependent patients. Could you give me some your ideas or some impressions of the parents? How do they say? Thank you.
Yeah, thank you for wonderful questions. In this study, there is no addictive pattern of using this application. Actually, my two daughters are secondary school students. They have already smartphone. So I think this application can be used effectively for teenagers also without any addictive risk.
Thank you. Thank you.
Thank you very much. So we welcome the third speaker, Dr. Raffaele Popolo from Rome. His speech title is The Metacognitive Interpersonal Model in Psychosocial Rehabilitation. Yes. Thank you, Paolo. Thank you. Raffaele, please.
Thank you. Thank you, President, and good afternoon. In this study, we present an application of a metacognitive interpersonal perspective to rehabilitation in young patients. Our work started from the idea that the goal of the treatment of psychosis is the improvement of quality of life. For this, symptomatological remission is only a part of a more complex management of treatment, and that should also improve the social functioning. That deficit of social functioning constitute main aspects in the schizophrenia. These deficits are correlated with outcomes of treatment, relapses, worsening of patients, and with unemployment. They are present before the onset of schizophrenia. If we want to increase the social functioning, we have to intervene on the dimension that support these malfunctions. Social cognition has been identified as a dimension correlated to social functioning. By social functioning, we mean a multidimensional construct that includes a wide range of abilities, such as identification of emotion, social perception, theory of mind, and attributional style. We can observe malfunctions of social cognition early in the psychosis. Young patients show deficits in emotional identification, and these malfunctions were associated to difficulties in social functioning. In early psychosis and in prodromal phase, we can find frequently tone impairment. By theory of mind, we refer to the ability to infer correctly mental state to others in order to predict their behavior. Several studies found association between theory of mind and the social abilities. But social cognition is is part of a wider metacognitive function. By metacognition, I introduced the concept of metacognition. Metacognition is, by metacognition we refer to the set of abilities that allow us to understand mental phenomena and use them to solve problematic states. Impaired metacognition is there are a lot of studies. For example, our group worked with Polysaccharide in USA, and then we find that impaired metacognition is a potential contributor to poor insight in first episode, and it is correlated with more social deficits in these patients. How can improve the social functioning in our patient? We can achieve this purpose if we stimulate the dimensions that support this malfunction. And social functioning, we have to stimulate the skills that allow to the patients to develop of a relationship, to improve this management and the organization of everyday life. In our perspective, in the metacognitive perspective, rehabilitation focuses on developing and enhancing the correct identification of own mental states as others. In this study, we present a model of rehabilitation of metacognitive functioning. The sport intervention that we present consists of 9 months of social activities divided into 2 phases. A group activity of 120 minutes twice a week, including training and the match. And then a metacognitive therapeutic group session. This group session has a duration of 90 minutes once a week. Our hypothesis is that the metacognitive functions can be trained in the relationship. Within the rehabilitative context, an intersubjective dimension between operator and the patient is structured. This dimension allows interventions on the metacognitive function. The training of the function takes place in informal communication between patient and operators during the sport activity. And then in a structured way during the weekly group. Now we briefly describe how the therapeutic group takes place. Initially, the conductor asks the group to report emotionally significant experiences. Then the conductor picks one or more dimensions, one more episodes to analyze in detail, points out the main issues involved. At this point, the group discusses, starting from the episode selected. Each patient can describe own emotional states, own experiences, avoiding intellectualization. The conductor stimulates patients to reflect on the issues by validating statements and encouraging sharing. At the end, the conductor summarizes the themes and highlights the skills used to solve the problematic state, the episode selected. The aim of this study is to analyze the effect of this training program on social functioning, quality of life, insight, and psychopathological dimension in psychiatric patients with a diagnosis of schizophrenia. In particular, we want to see if there are differences between patients at the early stages and chronic patients. We compared two clinical groups. The first group is composed by 70 patients aged between 18 and 25 years. All the patients are schizophrenic patients, of course. The second group is composed by 15 patients aged between 26 and 35 years. All the subjects were recruited among patients in the Psychosocial Rehabilitation Center of Mazzacurati of the Department of Mental Health, Rome 3. Evaluations were conducted by expert psychiatrists with experience in the treatment of patients with severe conditions in accord with the DSM-4TR criteria. We considered all schizophrenic patients without any other disorder in comorbidity. In order to evaluate theory of mind, we used the following tools. To evaluate affective theory of mind, the ability to recognize emotional states of others, we used the reading the mind in the eyes. That is an advanced test to identify mental states by evaluating facial emotions and expressions. To evaluate cognitive theory of mind, the ability to understand the thoughts of others, we used two tests with two different stimulus. The Indian test that use an auditory stimulus and the theory of mind picture sequencing that use a visual stimulus and images. For the psychopathological evaluation, we used the positive and the negative syndrome scale. In our analysis, we considered, in addition to the total score, the negative scale that is the most linked scale to the social functioning. To evaluate the ability of insight, we use the Beck-Conley Insight Scale. That is a self-administered questionnaire composed by 15 items. We used the global sensory functioning function to evaluate, to assess the social functioning, and the short form of health survey to evaluate the quality of life. In our results, we focus on two scales that obtained the significant results: the mental health and vitality. Now, we can see the results. This is the first assessment of the two groups, of the two clinical groups. The two clinical groups were not different among the clinical variables. The difference is not significant, have not statistical significance. After the treatment, the young patient showed a significant improvement of all clinical variables, except for the insight. Instead, the chronic patients show no difference in all clinical variables during the treatment. In this table, we can observe the evaluation baseline of theory of mind of the two clinical samples. We can observe chronic patients have a worse functioning, and these differences are statistically significant for cognitive theory of mind. After the treatment, the theory of mind in a young patient improve in all the also in theory of mind, in affective theory of mind, and also in cognitive theory of mind. The changes are significant for the items of the cognitive theory of mind. In the chronic patients, the chronic patients didn't show significant changes in the course of the treatment for the theory of mind. This is a discussion. The training program has positive effects on social functions, quality of life, and the psychological dimensions in young patients and not in chronic patients, with the exception of insight. This is for us a question, an important point to reflect, because in other articles, in other studies, we found a correlation between insight and theory of mind. In particular, from insight and cognitive theory of mind. This intervention improves theory of mind abilities in young patients and not in chronic patients. Some abilities seem to respond better to the sport intervention in the early phase. In the later stages, or in patients not in early phase, different interventions on metacognitive abilities. We elaborated two model of intervention for the metacognitive abilities. Metacognition-oriented social skill training and metacognition interpersonal therapy in a group setting. This approach could be useful for this patient with a long duration of the disease. In future studies, we will focus on correlation between clinical variables and the TOM. Our study presents some limits. Pharmacological treatment may have impacted the results because may influence the answer of the patient at the tasks. Our sample is small, and we can generalize our results. Patients were recruited from a single rehabilitation center, and that can determine a possible selection of a bias. An important for us limitation is the use of tests to evaluate tasks, to evaluate the theory of mind, because we need a new instrument, other instrument to evaluate in the real life, in the real world, the metacognitive functions of these patients. Thank you for your attention.
Your speech. Some questions? I have a question for you. Oh, sorry.
Thank you for your presentation. Just short comment about you link together physical health and mental health. After the physical training, followed by mental training, and within this physical training, you can see another secondary goals. For example, the fun, the feeling of belonging, or other goals. So it's better to start with a physical warming up, and then followed by cognitive training. Thank you.
The sport activities allow us to develop, first of all, develop a sense of belonging between the patients. In this dimension, in a dimension of belonging, we know that metacognitive function can improve rapidly. And then, if we in a state of enjoy, of joke, and positive emotion, when the patient feel positive emotion, it is possible to improve better the metacognitive function, because we decrease the arousal, the emotional arousal. Then the physical, but also during the sport activity, we can training the metacognitive, because metacognitive functions, because the single operator is oriented into this perspective, and then is stimulated with simple questions. How do you feel? What do you think when you cross the ball to the other patient? And then and this is a training in real life, then, and not how I said, in our limits in a laboratory, where there is a dual relationship, but not in the context of real life. Then the rehabilitation permits us to use this context different of a study where usually we worked.
Okay. We have some times for explain better your task, the task you used in this study.
Okay.
2 minutes for talk.
We selected to evaluate metacognitive functions. There are a lot of instruments, a lot of tools. Some of these, like FR of Fonagy, is used to AI and transcript of an interview. We have elaborated another instrument, a metacognitive assessment scale, but this is difficult to use with a lot of patients. Now we thought to use different type of task to evaluate in different way the theory of mind. Then for example, we selected the theory of mind, the intent task. Okay, I have, this is not important, this is another, this, because I eliminated before this slide. And this task is composed by 10 briefly stories describing the interaction between two characters. Each story ends with, for example, Patricia is getting off the train. Now we read this sketch to our patient. Patricia is getting off the train with 3 heavy suitcases. John is standing behind her. Patricia says to John, "Wow, these suitcases are bother." This is this test is elaborated by Corcoran, and we translated in Italian, and now we are waiting to publish the translation. Now, okay, the evaluator will ask, what does This is the question to permit us to understand the second thought. What does Patricia really want to say when she says this? Now, in this case, with this test, we used auditory stimulus. But if we want to change the stimulus to evaluate the theory of mind, this is, for example, il theory of mind picture sequence task. It constitutes by 6 stories. Each one consists of 4 pictures, okay? And the patient has to put in order, but in a logical sequence as fast as possible. For example, this. But why we use 2 tests to evaluate? Because we want to eliminate the bias of the stimulus in this evaluation.
Okay, thank you, Raffaele.
Okay, thank you very much. And we welcome the last speaker from Naples. Today, Mario Luciano speaks instead of Andrea Fiorillo. The title is A New Psychoeducational Approach to Improve Lifestyle Behaviors in Patients with Severe Mental Disorders. So, Mario, please.
Thank you, President Mitsuno. Good evening to everybody. And I'm here on behalf of Professor Fiorillo, who apologized for not coming for personal reasons. In my presentation, I will talk about the study protocol of this research that has the aim to develop a psychoeducational approach to improve the physical health. I would like to start with some epidemiological data who give us the magnitude of the problem. We know and we have good evidence that people with severe mental illness have a reduced life expectancy. And this life expectancy gap is about 15 to 25 years. And we know that people with severe mental disorders have an excess mortality, and this is 2 to 3 times higher compared to the general population. Normally people think that people with mental disorder die because of suicide attempts, but that's not true, because about 60% of premature death can be due to physical illnesses. And then we know that more than 50% of patients have at least one comorbidity with physical disease, and up to 9% have 4 or more coexisting physical illnesses. Why this is important for young people? This is important because physical comorbidity appear early in life, and then we know that especially young people are at risk to develop substance abuse and viral infections compared to the general population. We know that the cardiovascular risk factor may develop quickly, and even if weight gain is reduced or if the weight is lost later in life, we know that the cardiovascular risk still persists. So it's very important that patients at the onset of their disorder, in particular patients with the first episode of schizophrenia, require attention both to physical and psychiatric health. Here I present you the relative risk to develop a physical illness by people with severe mental disorders. We know that this population have a 3 times relative risk to develop diabetes, dyslipidemia, respiratory difficulties, and 2 to 3 times relative risk to develop cardiovascular disease. Which are the factors that can contribute to poor physical health? Several factors. The first is, of course, the use of drug. drug treatment-related factors. We know that antipsychotic drugs are associated to several side effects, for example, weight gain, prolactin increase, cardiac effects, or motor and blood dyscrasias. And we know that people who take antipsychotic drugs are at risk to develop metabolic syndrome, diabetes mellitus, and cardiovascular disease. But antipsychotics are not the only drug associated to, for example, weight gain. We know that also antidepressants and mood stabilizer are associated with weight gain. So not only people with schizophrenia, not only people who take antipsychotic drugs are at risk to develop weight gain or other physical illnesses. The second are system-related factors. Schizophrenia, patients with schizophrenia have less access to health care. There are several reports that people with psychosis have a low rate of surgical intervention, such as stenting or coronary artery bypass grafting. There is a lack of care coordination among medical, social, and psychiatric stakeholders. And there is the stigma. The stigma prevents people with mental illness to seek for help for medical conditions. Then we have the physician-related factor. Psychiatrists usually tend to overemphasize the medical illnesses, tend to underrating medical examination. In some cases, there are reports that psychiatrists often have insufficient medical knowledge and so physical, there is a low level of monitoring for physical diseases. And another fact is that also because of stigma, because medical doctors from other specialties feels uncomfortable to deal with psychiatric patients. The last factor, but not the least important, are disease-related factors. Patients with schizophrenia or other severe mental disorder have usually lack of insight, lack of adherence to treatment. And adherence to treatment does not mean that patients don't take psychotropic drugs. This means that if a patient has, for example, hypertension, tend to forget to take medication for hypertension or for diabetes, for example. We know that there are several symptoms, such as cognitive deficits, can reduce the help seeking. And we know that patients with severe mental illness have unhealthy lifestyle behaviors, are usually heavy smokers, usually have a lack of physical exercise, poor diet, junk food, and high level of sedentarism. For this reason, we know that it's important to address this. And we know this from several times, because this is an article published by Professor Prince, Patel, Saxena, and Professor Mai 9 years ago and on Lancet. And they, No Health Without Mental Health is the title. It's very evocative. And they claim for development of psychosocial intervention that can be integrated into management of communicable and not communicable diseases. We are talking about 9 years ago. Something has been done. We have the World Health Organization that promotes a campaign to improve physical health of the general population, and they suggest to encourage people to refrain from tobacco use, take regular exercise, have a healthy diet. And as a matter of fact, several interventions has been already developed and already tested, and have reported to be very effective in patients with severe mental disorder. And there are some interventions that are directly address directly people at the onset of their disorder. But NICE guidelines says that it is very difficult to develop recommendation about lifestyle intervention in people with severe mental disorder, because there is a paucity of evidence, and because there is the need of large RCT trial with a long follow-up. So, for this reason, we tried to develop a new model, a new intervention, also because In Italy, we have some of these interventions, but we don't have an intervention that addresses globally lifestyle intervention. So we receive a grant from the Ministry of Education, University and Research to develop this intervention. We have, in Naples, we have the coordinating center. There are other 5 universities, Rome, Pisa, Genova, Bari, and L'Aquila, that will collaborate to this project. With what is the primary aims? The primary aims is to test the efficacy of this intervention to improve physical health. Physical health will be measured as the severity index of cumulative illness rating scale by a reduction in body mass index and in waist circumference by a reduction on plasma level of glucose, cholesterol, high density lipoprotein, and blood pressure. We will take into account 2 indexes, which is one is the HOMA index, who assess the insulino resistance in patients with severe mental disorder, and the Framingham index, which assess the cardiovascular risk. We have also secondary aims because we would like to investigate if this intervention is effective in changing lifestyle behaviors and in improving psychosocial functioning, quality of life, psychopathology, self-esteem, and social networks. Another aim is to identify factors for poor response to psychosocial treatment. Poor response does not mean that does not mean to identify only patients-related factors, but also structure-related factors that can impair the efficacy of this intervention. We know that structured interventions are very difficult to be implemented in the real life and in the routine of people with mental disorders. So identify risk factors, it means identify barriers, also barriers in the implementation. And then we would like to test the psychosocial intervention in different study populations, psychotic, affective disorders, and to test the efficacy in the long term. Moreover, we will try to develop the clinical guidelines on the basis of this experience and to test the cost effectiveness of this intervention. These are our inclusion criteria. We designed a randomized controlled trial, and usually these RCT trials have very narrow inclusion and criteria. We wanted to have a broader inclusion criteria because also if this is an RCT trial, we want to include people from the real world, people routinely seen in the mental health center. So we keep a wide age range, diagnosis of psychotic, bipolar, or depressive disorder, and at least 1 monthly contact with the mental health center. This means that we want to see patients that normally refer to the Italian mental health centers. We will try to recruit 420 patients. We assess sample size according to our main outcome that will be randomized to receive a lifestyle intervention, 35 patients per center, and a brief educational intervention, 35 per center. We will have psychosocial assessment at baseline after 6, 12, and 24 months. Then we will have biochemical assessment at baseline after 2, 4, 6, 12, and 24 months. Assessment. We will assess lifestyle behavior, food, physical activity, smoking, sexual habit, quality of sleep, dependence, and adherence to pharmacological treatment. Then we will assess psychiatric and psychosocial status with a brief psychiatric rating scale, quality of life, self-esteem, recovery, social network, and functioning with a specific level of functioning scale. We will have a cost effectiveness evaluation with this scale. It is not translated in English. And then we will have a cardiometabolic risk assessment. Which are the characteristics of our intervention? The lifestyle intervention we developed is a group intervention with 10 patients maximum. 25 sessions every 7-10 days. Each session will last about 19 minutes and will include 20 minutes at the end of physical, moderate physical activity. At each session, we will have a weight assessment at the beginning of the session. The intervention has been structured to be performed by all mental health professionals. This means psychiatrists, psychologists, nurses, educators, and psychiatric rehabilitation technicians that are a special figure, professional figure that we have in Italy. And all participant mental health professionals will receive a 5-day intensive training courses. We will usually not include experts in diet and physical activity for feasibility reason. In Italian mental health center, there is a low level of resourcing, so not always is available an expert in diet and expert in physical activity. So in order to promote the implementation of this intervention in the routine, we did not include them in running the intervention, but we keep their advice in developing the intervention. Our theoretical background is this: we take advantage from psychoeducational, classical psychoeducational techniques, motivational interviewing, and health coaching. And these are the modules: healthy diet, physical activity, smoking cessation, drug and alcohol abuse, risky sexual behavior, sleep hygiene, and adherence to pharmacological treatment. The model has been developed to be flexible. So if there are some groups that needs more session on healthy diet, the healthy diet model will be longer than, for example, risky sexual behaviors if none of the patients belonging to the group has this problem. Each module has 3 components. The first component is the educational components. We, in this session, try to identify what is the problem and why the problem is important, which are the consequences of unhealthy lifestyle behaviors, and what changes are needed, which are the changes and what is needed, and we provide, tips and advice to improve that specific lifestyle intervention. The second component is a motivational component. We try to focus on the benefit associated to the behavioral changes. We try to elicit patients' motivation with specific group session, and we try to plan strategies. Then, after the patients understand what is the problem, and after the patients have a right motivation, they can apply a change. But applying a change means also to have some problems. Then, the last component is a problem-solving component. We take the advantage of 6-step approach, which is typical from the psychoeducational intervention, to solve the problem. And we try to respond to this, to answer to this question. Does the patient has experienced any difficulties in implementing lifestyle changes? And the group setting is particularly useful in these cases because there is a discussion among other participants who try to help patients who express specific difficulties to help, that try to help him. Then, the control group. We don't have a passive control group, but all patients will receive an intervention, and the control group will receive an educational intervention consisting of 7 sessions. Each session will last 60 minutes. Also, in the control group, we have 10 patients maximum. Which are the topics: information on most frequent mental disorder, treatment, which are the most important treatment, pharmacological and psychosocial treatment, management of side effects and of pharmacological treatment, identification of early warning signs. Which are the strengths of our intervention? The first is that it focuses on all mental disorders. Usually, available intervention focuses on patients who take, for example, an antipsychotic drugs. This is the example of change trial. Or for people with schizophrenia or people with affective disorder. This could be an adjunctive value, and we will see if this will be an adjunctive value. we try to develop an intervention which is directly implementable in the routine of mental health care. So we take a special focus on the feasibility of this intervention. And the intervention has been designed to be very flexible and to be run by each kind of stakeholders that normally works in the routine care of Italian mental health centers. As I told before, experts in diet and physical activity are not necessary during the session. It depends by the resources of mental health center. And of course, it has been adapted to Mediterranean healthy behavior. This is another problem because the majority of intervention comes from other countries, from England, from America, from Canada, from Australia, and the diet is very different, and the attention to physical activity is very different. So we had the need to develop an intervention which is feasible in the cultural context of Italy. So we had to adapt this to the Mediterranean style. What is the expected impact? We would like to see if the intervention can produce effective changes in lifestyle behavior, especially in the early phases of disorders. And we will provide a subgroup analysis according to age and according to age and to year of illnesses. And we would like to test if the psychosocial intervention can be feasible and if it's associated with is a cost effectiveness, if reduce the direct and indirect cost associated to the treatment of people with mental disorder. This is an article published by Patel, Saraceno, and Arthur Kleinman 10 years ago, and they told us that the implementation of physical activity, implementation of physical health in people with severe mental illness is an ethical and a moral question. And after 10 years, we now are ready to implement this intervention, and we are ready to do something. Thank you for your attention.
Thank you, Mario, for a very interesting speech. Again, we have a question. I have a question. Oh, no. I have a question for you. You have used the guidelines for create your model. Which guidelines have you used?
Thank you for this question. We, in order to develop this intervention, we started from a research review because we wanted to know what are the already available interventions. So we have a quasi-systematic review to have a clear picture of the state of the art. We identified some intervention and we contacted the professor who were in charge for that intervention. We established, for example, a collaboration with Professor Green, who developed the STRIDE intervention. And then we get a look at already existing guidelines, not only in psychiatric fields. For example, there are the guidelines of the International Association for Diabetes, the guidelines for the European Association Society for Cardiology, the guidelines of European Psychiatric Association. And then we get a look at the guidelines of Ministry of Health of European countries and after of non-European countries. And we realized that in Italy, our Ministry of Health has developed some tips, not guidelines, but some tips for the general population to improve, for example, their physical health. They give advice on how to perform moderate physical activity. They provide advice to how to change their diet habits. And we found very interesting educational material from the National Health System from UK and from the Ministry of Health from Australia. Then we put all together and we developed some educational material based on guidelines and on already existing experience and tips coming from ministries of health of European countries.
Thank you.
Thank you.
Thank you. You can you can close. Thank you. Oh, thank you. My English is very Roman English, so I'm very proud to. we have shared our experience in different countries and different culture, and the attention to the body, the two, I think is very stimulating for our work in everyday work. Thank you for your presence.